Hello and welcome, everyone. My name is Kristen Talbot. I am the program manager for MAVEN project. Thank you all for joining us today and our friends at Cherokee Health Systems for hosting today's session, Atopic Dermatitis, Itchy Infants, What's Wrong and What to Do with Dr. Susan Boiko. Dr. Boiko is a clinical associate professor of pediatrics and dermatology at the University of California, San Diego School of Medicine. As a pediatrician in the Air Force, Dr. Boiko became interested in the rashes, moles, and birthmarks she observed on her patients. After completing a dermatology residency, she joined the faculty as a pediatric dermatologist at the University of Cincinnati and then spent most of her career as a general dermatologist at Kaiser Permanente in San Diego, where she also served as a voluntary professor of pediatric dermatology at UCSD. Upon retiring, she joined UCSD as a part-time associate clinical professor of pediatrics and dermatology, and we are so thankful to have her as one of our MAVEN project volunteers. So Dr. Boiko, when you're ready, please begin.
I'm so honored that Cherokee Health has invited me to give this third talk to you. And I have about 77 more talks, so as long as I'm alive, if you keep asking me, I will have a talk for you. I'm very interested in atopic dermatitis. And here's my disclosure. I don't own any stock in any products that we'll be talking about today. MAVEN Project doesn't have a specific disclosure about this, but I do want to let you know that I will be talking about off-label use of products in children, and that we are accredited for your CME. Today, I'm hoping that you will learn some very simple ways to immediately soothe an itchy infant or child right in the office as you're seeing them. There's nothing worse, and I often teach the residents and fellows in my clinic about a physician or a healthcare practitioner trying to scream over the screaming of a child who is miserable to give some kind of instruction. So if you can make them comfortable first, it'll be a lot easier later. Also, in your notes, it's very important to document the severity and the extent of atopic dermatitis and any other social determinants of health, which we'll discuss exactly what those are. And finally, to present a written action plan for treatment. You give that to the parent, they can put it on the refrigerator or tape it up to the bathroom mirror so they can know exactly how much medicine to use. So sometimes people are confused between the words eczema, which is the Greek word to weep or boil. And you could see that these children's skin looks like it may be weeping a little bit. Atopic just means that there's no place. It's a word that was coined in the 1920s, and it's kind of a weird name. If you think about a topographical map, that means the surface. So atopic means it has no surface or no place, but there it is right on the skin. So no matter what you call it, it is the most common pediatric skin disorder. And many of you will see this coming on in little children as young as a month or two of age. And it's amazing to me, when I first started in dermatology, it was relatively less common, and children with severe disease were coming to our pediatric dermatology clinic in Cincinnati in the 1980s, which was one of the first clinics to be interested in this condition. So it's very important, just as we talked about hemangiomas last time, that if you see something that means that the child may be in ill health otherwise, you kind of put the consideration of the skin second, and you try to address the more important issues. For example, if the child is not thriving, if they're falling off the growth curve, if they're not eating, if they're having recurring infections, that could mean that there is some genetic consideration going on that is preventing the skin from reacting normally to the environment. And speaking of environments, one thing that we always have to be aware of is if our patients have food and housing insecurity. I'm sure many of you remember when there were the formula crises where parents who couldn't breastfeed suddenly found that it was very difficult to find, let alone afford, formula. and unsafe housing with poor housing conditions with mold that can contribute to allergies and asthma, and lack of heat or lack of air conditioning in those hot, steamy Chattanooga summers can also provoke skin problems. So think about children in North Carolina, and part of the reason I'm showing this picture is kind of irrelevant to our discussion today, but very important to saving the life of children, is that often children of color are not taught how to swim, and so they're more likely to drown. So that picture is there for that purpose, and that you'll see that that comes from Black Kids Swim. But it's also a picture to remind you that if you have an African American child and they have eczema, they're more likely to live in a rented home. They're more likely to live in a racially segregated area, and the caregivers may have a lower level of education, which would impact your talking with them and having them understand exactly how to follow instructions. Since if you look at many instructions that are put out for parents, you'll see that the literature is commonly written at a 10th grade or higher level. In fact, when I look at our Pediatric Dermatology Society handouts, often those are written at the college level. And smokers in the home certainly aggravate pulmonary problems. So one thing that's really tough in every situation is not just eczema, but especially in eczema, is why don't parents follow our advice? And sometimes it's because they're afraid of the side effects on the skin, or the children seem to get a little better on their own, or they feel like the medicine doesn't work. And when they say the medicine doesn't work, I ask them, did it work while you were using it? But then when you stopped it, did the thing come back? And that's about 90% of the time. The medicine will have worked while using it, but it didn't work to go away because families often don't have the concept that this is potentially a lifelong inflammatory condition, not something like a strep throat that gets penicillin and gets better. So how do we get families to trust us? So I often use this metaphor to parents. I tell them that I'm using a steroid because I want to put out a fire with a fire hose. The child is lying there writhing on the exam table, itching and rashy all over. So I say, you know, this is like a fire. We don't sprinkle a little water on this to make it go away. And then we can use a garden hose, which will be more of a trickle, to keep the garden growing, which will be the weaker maintenance steroids or the non-steroidal products. And then remember always that as you're talking to families, from the time children are infants, they are also hearing you. They're hearing your voice and seeing your body language. And so if they see that you're kind of looking away from the parents or you're not engaging the child, they'll feel like they're not a part of the visit. So two things that I mentioned, and we will go into more depth as the discussion continues. There's a medicine called tacrolimus or tacrolimus. No matter how you say it, people are afraid of it because it has a black box warning. But I tell them that over 20 years of using it, there is no increase in cancer for the use in this purpose. And also that topical steroid misuse is unlikely if you follow the guidelines. So first thing that you need to know is, what are they using? These were sisters that I saw, and you can see every product under the sun that the parents had used, hoping that it's called hope in a jar. You hope that whatever in this jar is going to cure your problem. But sometimes I found, for example, a child who had atopic dermatitis, and the mother said, every time I rub this cream in his skin, it gets redder. And she had the cream with her. Well, it turned out that in those days, 1% hydrocortisone cream was prescription. So they had taken a tube of nitroglycerin cream, which should be used to treat people with heart attacks. And they had put a 1% hydrocortisone label over it. So no wonder the child's skin became red because of vasodilator. So that way you can find those mistakes. And you can also find that the Polish family that got a tube of medicine called clobidazole from Poland and were putting it all over their child because the Polish medicine seemed to work very well. So have the family bring everything in, including their own hand cream. Parents who use their own moisturizers and then touch the children may inadvertently be causing a reaction. So we want to have a respectful collaboration, even if we may feel that some of the things parents are using are less effective. As long as they are not a danger to the child, I think it's all right to go along and observe. But oftentimes I'll tell parents, I'd like you to try my suggestions, but I'd also like you to compare them to what you're doing now. So just divide your child in half from top to bottom. And on the right side, put your medicine, and on the left side, put my medicine, and see what wins. So our common ground is what we call soak and seal. We're going to moisturize the skin by soaking the child in water and then sealing the moisture in with moisturizers. Things like fish oil, probiotics, and melatonin. One concern about melatonin is it really hasn't been effectively studied in young children, infants, and children under the age of 5. So that's a whole other conversation about, instances when I would use it. But I feel like rather than turning to melatonin to have children sleep better when they have eczema, I'd rather control the surface of their skin so that they're not scratching so much. And remember that when I say eczema and atopic dermatitis are interchangeable. So foods and anti-inflammatory diets, we have to be very careful that these diets are not elimination diets because then children can become malnourished. So my first tip, and this is actually a picture of a child in my office, is I take petroleum jelly on one end of a tongue blade, and then I take vegetable shortening like Crisco or other brands of shortening. They're both edible, so I tell the parents if the child licks this, it's not going to hurt them. They're always worried that they'll ingest it. And then I have the child and the family members all touch these things and see which one they like better. And then I say, which do you like better? Okay, now the child is actively itching or uncomfortable. So we take the one that they like. So I just take a paper towel, crumple it up, put some tap water on it, dab it on the skin, and then coat the child with either the shortening or the Vaseline. Now the itching is momentarily calmed. We get the clothes back on, and then in the comfort of the parent's lap, we can continue the discussion. So this is a little boy, and you'll see a picture of him a little later on. His neighbor made him these gloves out of her old t-shirts because he was scratching so much that he was actually tearing his skin and bleeding. So he had severe atopic dermatitis. So in each visit, I say whether it's mild, moderate, or severe, and you'll find the criteria for that coming up. I say how much body surface area is affected. This is important if you're talking to insurance companies for prior authorization where they feel like, well, maybe the child only has a mild case or they don't really qualify for this treatment. So just to use the child's palm, that's 1% of the body surface area, easy to calculate. And then make sure that you're always looking at their growth and development and understanding their social determinants. I had a mother who had a child with a severe congenital problem that looked like the very worst atopic dermatitis you ever saw. She was homeless. And so she would steal jars of Aquaphor because she had no money and her child literally needed a jar of it a day. So working with the manufacturer of that product, I was able to get her a case of medicine, which she was able to take with her as she went from various shelters so that she wouldn't feel compelled to stealing. So mild is just a little patch. Many of you may have one of these little patches, especially around your legs this time of year as it gets a little chilly, even in Chattanooga. And it's a small involvement of the body surface area or a large surface area with mostly dry, flaky skin. Also, besides seeing the little excoriated, slightly crusty, pink, thin plaque on the wrist, look at the palm. Do you see how very hyperlinear the lines on the palm are? If you see this, often you'll see this at the parents too. You ask them to pull up their pants legs and you'll see that their skin is flaking on their legs in the winter. This means that when you have hyperlinear palms and soles, it often goes along with a defect in your ability to make keratin protein in your skin that properly holds moisture. Moderate is when the children are itching more. You see them actually scratching in the office. They can have intense localized inflammation or widespread areas. And those are, I call those hot spots, the place where the kids' fingers will always travel to. And hypo or hyperpigmentation, especially in children of color due to inflammation. You'll often see parents like slapping the child's hand a little bit or trying to pull it away and say, don't scratch. You can't say don't scratch. I'd like everybody now to just take your fist and make a fist. And now with that fist, I'd like you to kind of rub your leg or your arm. And that is the proper way to scratch, because that will, your nails will not tear into your skin. So that'll give you the relief you need, but it won't do damage to your skin. So I always say to the kids and the parents, like, if you see your kid scratching, don't say don't scratch, say knuckles, and they'll make their fist and you can scratch with that. Also, you could just take cold soda pop cans, make it a flavor nobody wants to drink. Just keep that can in the refrigerator. When the kid is badly itching, you just take that can out of the refrigerator, press it against their skin where they're itching, and that will give immediate relief because the pain of the coldness will supplant the itch. So my severe patients, I often characterize as severe if they can't sleep at night, regardless of how their skin looks. If they have a constant itch, if you look at their fingernails, you see that their fingernails are shiny, they're buffed from scratching so much, and they have bloody crusts under their fingernails. Their fingernails are black, not from dirt, but because they've been scratching till they bleed. And the skin will be thick and it will look like impetigo and have honey crusting. You can see this picture. The mother has made these little sleeves out of socks for the kid. And then just where the sock ends, you can see the tremendous inflammation on the skin, the peeling, and the scabbing. So this is the little boy that you saw in the picture before with the handmade gloves, the homemade gloves from his neighbor. This is what he looked like as an infant, and I was very pleased to be able to follow him until he became a teenager and he had more dry skin, less of this thickening and this incessant itch that caused him not to be able to sleep at night. So lichenified means the skin looks leathery. It looks like a leather purse. It may be over the entire body. There's bleeding. Sometimes there's oozing, and the fingernails are shiny. Look at his hands. See how his fingers look a little edematous, but they're actually just thickened from the constant scratching. Here's another child with severe atopic dermatitis, and we'll come back to this image later, but look at the hands scratching the legs. As bad as those legs look, the hands look even worse. The child's probably gnawing on their hands as well. And this is a child that's not sleeping at night. And when you see this, you want to ask the parents if they're not sleeping at night too, because I tell my families, it's very important to get this under control, because I don't want you to drive off the road due to lack of sleep because your child's been up all night. One very dangerous thing that I, as a pediatric dermatologist, don't do, but many of my colleagues in primary care and some even in allergy do, is they will use systemic corticosteroids. They'll give a 3-day pulse of prednisolone for atopic dermatitis. It's very tempting to do this because you'll see the kid will get better over a day or two and they'll be a lot more comfortable. But then as the steroid wears off, they go into a repeat cycle because you haven't done anything to really suppress the underlying inflammation. So I show this picture of this kid with this horrible atopic dermatitis. It may be very tempting to you to just say, oh, let's give you the prednisolone. But I actually found in my practice, meeting other families where they would take their child across the border and get them steroids because the steroids helped so much that they kind of ignored all the warnings about it, and paradoxical to all the parents who are afraid to even put a little hydrocortisone on their kids. They just needed that peace, and the child needed that peace of not being able to scratch, but it caused a permanent damage to the child because of the repeated systemic steroids. I was surprised my colleague Amy Paller, who's one of the world's experts on atopic dermatitis, said that about 25% of American children, so if you, it's 125,000 children with atopic dermatitis have gotten systemic steroids. So please find every possible alternative to giving that pulse of prednisolone. Now, of course, if the child has terrible asthma and they need it so they can breathe, that's a different story. But just to use it for the skin alone, please use every other resource you can. So this is Dr. Schachner. This is one of my colleagues and heroes. So Dr. Schachner, instead of saying, here, put this on your skin for a few days and good luck, he made a whole comprehensive plan on how to treat atopic dermatitis in the office. So this is his little scale and rules. You can see it looks like the old printing from, if any of you are old enough to remember the first Macintosh computers in the 1980s. So he has these basic rules. Short nails, short bands. Now, you want to start a fight among people, it's about bathing. If you're a dermatologist, to me, let the kids be in there until their fingers are pruny. They're not pruny because they're dehydrated. They're pruny because they're overhydrated. But short nails is really important, and the nails need to be smooth too. Cotton clothing, the reason you're doing cotton clothing is you're trying to avoid overheating from some synthetics. Also, cotton can absorb some moisture. The problem with cotton clothing is if it gets too wet or sweaty, it's like a wet diaper against the skin. It can be more irritating. So you, by trial and error for the individual patient, you see what works best for them. A cool environment is very important. Laundry, the hypoallergenic detergent without bleach or fabric softener, is to prevent perfumes and irritants be on the clothing. So here's the ladder. You can see the lower the rungs are on the ladder, the less likely you are to get hurt. But you can also see the mother in the picture lurking in the background, ready to help Superman just in case he falls off his ladder. So the reason we call it a therapeutic ladder, because the lower rungs are the safest. So what's the lowest thing you can do that's not going to harm anybody with eczema? You can put moisturizer on twice a day. You know, like, it seems like this is a great idea. I have dry skin in the winter. Do you think I managed to get twice daily moisturizer application? No, but just for infants and children, and if there's a parent or caregiver or even a daycare that can do this at least once a day, it's going to give them great relief. Again, the short, smooth nails are really important. Inside out clothing. Why? Because think of your own clothing right now. Just reach inside your sleeve and you'll feel that little seam. To us, that doesn't bother us, but to somebody whose skin is already irritated, just another irritant. Fragrance-free detergents and fabric softeners, and then air conditioning and fans. And for you in Chattanooga, you're going to have to reach out to charities for air conditioning, fan donations, and installation. For us in San Diego, we have a medical baseline allowance for people with medical problems, so they get their gas and electricity at the lowest rates. And air conditioning due to a condition, so I can get a lower rate for my patients with atopic dermatitis for air conditioning. There's a form you can submit online. But I did call the utility in Chattanooga to see if they have this, thinking, well, it must be everywhere. No, they don't offer direct assistance. You have to call a United Way or 211 to get some assistance with that expense. So yes, this is a very long, busy form. So now we're going to go away from it and we're just going to break it down. So you don't have to use this particular form. Just take away some of these thoughts and processes so that you can make your own form that's understandable to you and your patients and that you enjoy using. So in the bath, you're going to use a mild fragrance-free soap. And here's where I can put in a plug for inexpensive products. The reason I'm mentioning these products is just as an example. I don't endorse the use of these products, and you don't have to use these products, but the Dove bar that is fragrance-free is very affordable. And there's a product that you can buy at Target called California Baby that has very few allergens. You can use that. The places that you want to put soap on are places that are dirty or weeping. like if the cheeks are chapped and weeping, if the underarms are at any occluded area, like underarm, stiper area, hands and feet, those places need soap. If there's a place where there's not much inflammation, you don't need soap there. And when you pat the baby dry, basically you can just kind of roll them up in a towel. You don't want to try to rub their skin, that just becomes more irritating. And they don't have to be like bone dry, you just want them to still be a little damp, because that's what the soak is. They've been sitting in the bath or they're in the shower, and then you seal their skin with the emollient or moisturizer. So you probably hear a lot about bleach baths. Some of you may recommend them. And this is a way to do a bleach bath. It's from the National Eczema Association, which is a terrific resource for families and for yourself to learn about eczema or atopic dermatitis. And so how does a bleach bath work? The bleach actually is an anti-inflammatory product. I had breast cancer in 2008. And at that time, they were just starting to do research that said if you had radiation for breast cancer and you use cloths with a diluted solution of bleach over the radiated area, you would be less likely to get a radiation-induced irritant dermatitis. And it is very helpful for inflammation. It's very controversial about whether it really does prevent staph infections, but it really, I find it more helpful as an anti-inflammatory. And you have to make sure that you use the proper concentration of bleach so that it's the same level of chlorine as your average swimming pool. So it's a half a cup of bleach to a half a tub. Like if you fill up your tub, and who fills up their tub to the top, because the kids are going to splash it all out. So usually it's better to just say just a quarter cup. And if you have a baby bathtub, just a tablespoon. And then make sure that with that tablespoon, then you're putting it somewhere where the kid can't get it, or you're rinsing off that tablespoon, because you don't want the kid to pick up the tablespoon and put it in their mouth. And just go ahead and soak and then rinse off with tap water. So the moisturizers that are our friends can also be our foes, because some of the ingredients in many of these products actually can contribute to irritation or allergic contact dermatitis. So I'm a big label reader. To me, these names are important. To you, you may not be familiar with many of these things, but chamomile, you think it's soothing like chamomile tea, but it's also botanical. It's also a plant, and people can be allergic to it. And aloe, the same thing. You think, oh, great, I'll just have an aloe bush in my backyard, and when kids get a burn or a cut, we'll just like rub the aloe on. But you can become sensitized or irritated to it. And mineral oil too, tocopherol, which is a vitamin. All these things can make the child's skin worse. So I've found several children allergic to some of the products that you see here just from common use. So these products have no common allergens in them. But you can see, starting at the top, this Bastilla Stilotopia emollient is $25 for 6 ounces. That really puts it out of the range of most of my patients. The Vanicream moisturizing ointment that we used to recommend is no longer in stock. They're reformulating it. But I really like this particular Spectrum Organic Vegetable Shortening, or Crisco Shortening, which does have some allergens in it. Because it's first of all, it's the middle of the night, the kid's terribly itching. You can find this on the shelf in the supermarket. And for people who find the Vaseline is too greasy, so they won't use it on their children, this is much less greasy, and there is no scientific evidence saying that this is better or worse for children with atopic dermatitis, but it's something that's commonly recommended by pediatric dermatologists. And then, of course, the petroleum jelly, which you can always say is a natural product. Remember that it's made out of dinosaur bones and old vegetation from millions of years ago. So it is, you can get a huge container of petroleum jelly for $6. So most allergens in products are things like Gold Bond. Some of the hydrocortisones have fragrances and preservatives in them. I think it's kind of sad that a product that's called eczema relief flare treatment has common allergens and things that are natural, wild, natural, and natural wellness, yet they have all these preservatives. And remember, these preservatives are put in the products because they're often creams or lotions. These things can spoil, they have water in them, so they have to have preservatives. And then because some of the chemicals in them don't smell good, they have a fragrance added to them too, and the fragrance can be an allergen. So here is Dr. Schachner's what he's telling people to use for prescribed medicines. The reason that there is a red line through clobetasol, I will come to later. But for now, what I'd really like you to focus on is triamcinolone, alclometazone, and emollient. So basically, what you're doing in the morning is feel free to dampen the child's skin with a little wet paper towel or wet washcloth. And then to all the hot spots, any place that's red, any place that has scratch marks, or any place that was flaring up and it's kind of calming down, that's where your medium potency topical steroid, and you can use either the TCI or PDI. I'm sure you're saying, like, what the heck is a TCI or PDI? We'll come to that in a moment. But mostly for what you're going to have on hand in your first thing that you'll use is either a medium potency steroid or a low potency steroid. And for places where the skin seems to be a little more healed, you can use a low potency steroid. I know it's kind of confusing, like what's the difference between a slightly red area and a pink area? So for my purposes, I mean, this is Dr. Schachner's ladder, but I will either, depending on how the child's doing overall, I'll have one or the other. And then you coat the whole child with moisturizer, including the places you just treated with the steroid. That will seal in the steroid. And then when they come home from school, if you grease them up again after school, it's going to help them be less itchy. It'll reawaken some of the steroid in their skin to work better. So again, let's talk a little closer about the latter, that for the children with mild to moderate disease. So for these mild children, you usually start a low potency like hydrocortisone or aclometazone twice a day for 3 to 5 days. And then for the places that could have a problem with steroids, including the face, the groin, and the body folds where the skin is thinner, or where you get increased absorption of steroid to make it more potent, you use one of the TCI or PDI. Again, we'll come to define those in just a moment. Once they're under control, you'll use the non-steroidal product, the TCI or PDI, to the hot spots for 2 weeks, and then you can maintain those indefinitely. So what the heck is a TCI? TCI is probably very familiar to you as the medicine called tacrolimus or tacrolimus, however you want to say it. And considering how most of these products are, it is relatively affordable. I remember this was about $80 when it came out 20 years ago for a 30-gram tube. And now it's $62 for a 60-gram tube. Of course, for many of our patients, even this amount of medicine at this price is unaffordable for them. But it may be, you may be able to prescribe it. The reason I really like these medicines, tacrolimus and pimecrolimus, is there is no steroid atrophy. Even if you try to harm your child, I tell my parents, by putting this all over their body every day, you can't harm them because there are no steroids in it. So it can't cause any thinning of the skin. It's safe for the eyelids, the external genitals, and the body folds. And so usually tacrolimus comes in 2 strengths, the 003 ointment, age 2 to 12, and the 0.1, age 12 and older. And then pimecrolimus cream, it only comes in 1 strength. So this has this scary warning, it has this black box. So I tell parents, like, yes, this medicine is given in a pill form to people who have organ transplants. It prevents them from rejecting their organ transplant, but I personally have seen in my career as a dermatologist many patients who develop skin cancer after 6 to 10 years of taking these medicines because they are making a bargain that they are willing to have their immune system suppressed so they can keep the organ to stay alive and have the side effect of them developing skin cancer. However, it would be like if you had wine. You would never give a full cup of wine to an infant. But if you had one drop of wine and you put it in the baby bottle, there's no way that they can be harmed by it because it's such a low concentration. So in Dr. Paller, the national and world expert on eczema, they did a study of 8,000 children with atopic dermatitis treated with tacrolimus ointment. One cutaneous malignancy and no instances of lymphoma were observed over the duration of the study. So their study was called APPLES. So they did not find any evidence that there would be an increased cancer risk in children with atopic dermatitis treated with this medicine. The reason that black box is on there is because when this medicine first came out over 20 years ago, a very conscientious pediatrician with the Food and Drug Administration was concerned about the medicine used for organ transplant patients and extrapolated that risk to children. There's another medicine that's called a PD4 inhibitor, or PDI, and that is the particular brand of that medicine is called Eucrisa. The generic name is crisaborole. If you were to buy this yourself, it would be $738 for a 60-gram tube. I don't think anybody can really afford that in my practice. It is FDA approved for 3 months and up. So it is an alternative for steroids for your younger children. It can be very irritating around the eyes, so it is safe for the face, but I wouldn't put it around the eyes. And if you have babies that are rubbing their face and it's getting in their eyes, they will not be happy. It tends to burn and sting quite a bit, so this is not always a popular medicine in my practice. But it is a steroid-sparing alternative for children, and some insurance and some Medi-Cal may cover it. For moderate eczema, for the kids that have some bloody areas or some deep scratch marks, maybe some difficulty sleeping, I usually start with triamcinolone using the 0.1%, and I like to use the ointment rather than the cream because the ointment has no preservatives and the cream may have a preservative in it. Use that twice daily for 3 to 5 days, and then use your topical immune modulator, your TCI, like tacrolimus or pimecrolimus for the face, groin, and body spots. And then you can use the tacrolimus or pimecrolimus indefinitely twice a day for 2 weeks and on. So if you're wondering how much to prescribe for a patient, instead of trying to figure it out yourself, you can use this wonderful calculator. So this is the address for the calculator. So you put in the age of the patient, you choose the affected areas, you say how often you're using it for how long, and then it will tell you the potencies, the types, the sizes, the amounts, and whether gel, solution, cream, or ointment, whichever one you choose. So you can just see by looking at this as it flashes on the screen, how helpful that's going to be so that you give the right amount. You know, there's nothing more discouraging than seeing a 6-year-old with total body, terrible atopic dermatitis, and they come with a 15-gram tube that the pharmacy gave. So again, this is a picture of severe atopic dermatitis or eczema. And once again, to remind you, don't use those systemic corticosteroids in these children. So the Schachner ladder, the reason I had crossed it out on the previous page was that I really wanted to call your attention to the fact that you can, in the severe children, as an alternative to using the potent oral steroid, you can use a potent topical steroid, which still has a potential for systemic absorption if you use more than 25 grams a week. But you may be able to put out that fire quickly if you need to take a drastic action. So that would be the high potency steroid. And then again, you would not use this on the face, groin, or body folds. And then you can keep stepping down. And You don't really have to go through this long rigmarole. You could just use this quickly and then like send a consult to Maven quick and say, like, can you give me a long-term plan for this child? So again, that's why I've crossed out the clobetasol in the evening. It's your emergency go-to if the child is miserable all over and you just got to do something and you were tempted to use oral steroids. You can just use this for 3 to 5 days and then use a lower potency steroid. So in the evening, once again, you're going to be putting on the steroids. Now, think about your own self and your own family when you were a kid or a teenager, or you had kids or teenagers. Are you going to be able to get anything on them in the morning before they get to school? No, you're trying to find their lunchbox. You're trying to find their other shoe. You don't have time to be throwing stuff on. If you can't do anything, you could even just give them a little moisturizer to put on the car or something, whatever you can do. But when they come home in the afternoon, then you can do the morning protocol. That's all right. And then the evening, you're doing these things after the bath or shower. Usually it's more convenient to do that in the evening. And then additional instructions to talk about antihistamines. My personal feeling is that antihistamines are useless in general in the treatment of atopic dermatitis in general, because either it's going to be sedating and the kid's just going to go to sleep. Like if you give hydroxyzine, like when I tell the parents in the past that I've used hydroxyzine or melatonin to help them to sleep, I'm using it to knock them out. I'm not doing it because it doesn't have any effect on their eczema in general. So sometimes people tell me they've used cetirizine, which is a long-acting hydroxyzine, as an anti-itch. I really find cetirizine more helpful for allergic rhinitis, itchy, watery eye symptoms, and urticaria. I find it less effective to help itching. Now, each kid could vary, so it may be helpful in your hands. A topical antibiotic, if you usually the rule of thumb is even if you see weeping areas, if you treat them just with the steroids, even if they are mildly infected, just the anti-inflammation property of the steroid can just clear up that infection. But if you see an area where you feel like you want to treat it for impetigo, use something like mupirocin. Again, oral antibiotics I use only in severe cases, and I get a skin culture before because I want to make sure that they don't have MRSA. For scalp care, I like to use an oil like the brand name Dermasmooth, the generic name fluocinolone oil. And I find that oil is also, if I'm just using the oil, then I use that as a medium to low potency steroid and can use the oil in other parts of the body. It spreads very nicely. The problem with the oil is it has it has a fragrance and it has preservatives in it. So I'm getting away from doing that. And then here is the information on this handout is not a substitute for the advice of your personal physician. So a little sidelight to say that if you find all this kind of daunting to make a big schedule on a program like this, go right to your MAVEN consult and say, have this kid send the pictures. Can you help me make a plan? You don't have to do all this stuff if you don't want to. I'm just mentioning it because if you start to feel more confident about treating some of these kids with milder eczema, it's nice to have a plan. So we have a new wave of biologic medicines for severe atopic dermatitis, and dupilumab is the first of many. So it's a monoclonal antibody that's blocking inflammatory mediators, and it's given by injection twice a month. It's FDA approved for ages 6 months and older. So this is a real game changer. Some of the children I had seen were so severely affected at 1 or 2 years of life that I was putting them on oral cyclosporin. And so it is $15,000 to $30,000 a year. But if you think about somebody not driving off the road because their kid was keeping them up all night, I think it's a reasonable price to pay to give the child that relief that's going to be so much more important to them and their whole household. Also, I want you to think of atopic dermatitis as a lifelong inflammatory disease, and think of other inflammatory diseases such as arthritis and heart disease and cardiovascular disease and strokes that we're just at the infancy of understanding how these things tie in to adult life. But if you can head this off in childhood, maybe that puts people at less risk for other inflammatory conditions later on. So again, here's the child before they received dupilumab. Here's the child in 1 month. Can you imagine going from this kid awake at night, scratching, miserable, bleeding everywhere, to, just a little boo-boo here and there from the scratching. Even look at that hand. Look at the hand here, how gnarled it looks. And then look at here how much more healed it looks. So dupilumab needs refrigeration. If you're traveling, this is a good tip for anybody who's traveling with medicine. You have to let the TSA officer know that you have these medicines, keep them separate from your belongings, declare your accessories. You'll need freezer packs, pumps, syringes, and labeling them will help you get through if you're traveling. And the final tip that I have for you is follow up with the patient. Very important. You can see I made this very primitive little good health calendars and used the Crisco shortening for the F is the fluocinolone oil, fragrance-free shampoo and soap, and like what can you use to wash with. And then the kid wrote their own little initials and things on there, and then I gave them a sticker or something. So really important to call and follow up or do a video visit to see what the next steroid is. How's the child? How are you and your family? How much medicine did you use? And try to be on video in person in the next few weeks. So in summary, the things that you can do in practice are to put a moisturizer on immediately in the exam room. Get the patient, as you're getting quick history and the kid is screaming and they're itching, and literally I have seen these kids writhing on the exam tables because they are so itchy. Just greasing them up, putting their clothes back on, maybe even inside out. And then that's the time when you sit down and talk to the parents about like what to do. Then in the medical record to say how severe it is, mild, moderate, or severe, how much body surface area is encompassed, and what's going on in their home. Like, do they have access to proper nutrition? Do they have access to heat and air conditioning? Are they able to wash their clothes? And then finally, to prescribe the correct amounts of topical steroids and give the patients an action plan. So I want to share these 3 websites with you. I think they're going to be extraordinarily important. I've given you a lot of information today. This is kind of like going to a buffet and telling you to load your plate up and then watching you eat it in 45 minutes. This is a big thing to digest. So if there are questions that you have that I haven't answered or that I may not be able to answer in the chat or in our discussion, please look at the National Eczema Association website. I think it's going to be very helpful for you. The American Academy of Dermatology's eczema information and the Society for Pediatric Dermatology's eczema information. And then these are handouts that are available on the website for the Society for Pediatric Dermatology and my references. So now I would like to look at the chat and then the Q&A and answer some of these questions.
Thank you, Dr. Boiko. This was fantastic. I just want to remind everyone that you can use the Q&A box, chat box, or use the raise hand feature to speak directly to Dr. Boiko. I'd probably recommend that because I will butcher your questions if they have medication names in there. But and so we'll get started. First question. I have seen some scare media where people are posting their topical steroid withdrawal experience. How can we discuss this and reassure or prevent?
So once again, their topical steroid withdrawal is a concern. There is a wonderful discussion of this topic on the National Eczema Association website. But what I emphasize to parents is that, yes, any medicine can be abused and harm your child, but if you follow the instructions, it will be safe. Yes, anytime you get in a car, even with a car seat and your kid buckled in, they could be in danger of being injured. But if you follow safety rules and you drive safely yourself, those are going to be minimal. So it's just like any other risk that you take. So I see somebody put in the chat, aloe is in the latex family. Thank you for that. And then I see for mild cases, can I use 1% hydrocortisone ointment on the face for a short course? So I think this is a great question. The problem is that, yes, the hydrocortisone ointment works great for a week, maybe even 2 weeks. The problem is when you stop it, the underlying inflammation is still there. So that's if you have a mild, even if you have a mild case, you'll want to transition to a topical immune modulator like pimecrolimus or tacrolimus. If you have a younger child, you might consider using crisaborole. And then I'm going to go to, when I click the link for the app in the App Store, it's not available in the US store. So try just searching for corticocalc, and then you should be able to find that app. And then, have you ever used a weak vinegar compress for mild itching? So a weak vinegar it's like a tongue twister. Weak vinegar compress is just mild acetic acid. So I think there's nothing wrong with using something like that. And again, maybe the acidic nature of it will make a little counter irritation, so you'll be itching less. And I'm going to ask Kristen to go on with the Q&A.
Great. I was trained that bar soap is a risk for bacterial soup brain infection. Thoughts?
So there's an easy way around that. When you get that bar soap, just take your vegetable peeler and just peel a little stack of it. And then you can just take a few of those little peels and use that instead of having the whole bar. If you're just using the bar for one member of the family, it doesn't really matter.
Is there anything mothers can do prenatally to decrease risk of atopic dermatitis? Does breastfeeding help?
I'm really sad to say that breastfeeding really doesn't seem to make a difference in the incidence of atopic dermatitis. For a long time, we said that it did, and I certainly don't use that as a deterrent, but the problem there, it's a multifactorial influence on what causes atopic dermatitis. And there's a genetic component, there's an environmental component, but please breastfeed anyway. And then take the advice of your physicians and your colleagues about what to do if the atopic dermatitis comes up despite the breastfeeding.
Great. Are there any vitamin or nutritional deficiencies that can contribute? We have a lot of patients with food insecurity.
Usually the vitamin or nutritional deficiencies like pellagra would be very unusual. But the time that I personally see more problems are either people where they have a global nutritional deficiency where they just don't have enough money to buy food. So they're using like rice milk or something in place of cow milk, or they just don't have any, they have protein and calorie malnutrition like kwashiorkor. I saw that a lot when I was in Africa. I think that if you are concerned with nutritional deficiency, it's very important to take a good dietary history and see if it looks like there is a problem with protein or there's a problem with certain vitamins, and then try to use whatever resources you have to get food stamps or supplements from grocery distributions or things like that.
Great. Any creams to avoid? I was taught Aquaphor can irritate the skin further, for example.
So if you look at the label for Aquaphor or many of these other quote unquote healing ointments, you'll see the first ingredient is petrolatum. And Aquaphor actually advertises itself as being 41% petrolatum. Well, why don't you just buy the 100% petrolatum? That's a good, a small container of that is $1.63 in any kind of big box store. So yes, there are ingredients in many ointments that are preservatives and fragrances. So you want to look for preservative-free and fragrance-free as much as you can. And luckily, those alternatives are inexpensive even in the grocery store.
Okay. Sorry. Do you advise against natural moisturizers like coconut oil? There are studies that using them on broken skin can sensitize the patient and in some predisposed to allergy to the product.
So again, like if there are parents that want to use coconut oil, I don't discourage it, but I tell them to use coconut oil on half of the skin and to use the products that I'm recommending on the other half. I recommend that people buy the unrefined product and use the solid product on the top because it's more substantive. It sticks better to the skin than the actual oil, which tends to roll off a little bit.
At what age can you start using a high potency steroid like colbestrol?
Oh, clobetasol? That's
Sure.
all right.
I told you I'll butcher
You're
those
doing fine,
medications.
Kristen. I think that the concern about using a product like clobetasol is that it's going to have systemic absorption. There are pictures in the medical literature of a child that the parents bought a tube of 1% hydrocortisone and they used it every day. They put an entire tube of 1% hydrocortisone on a young infant. And at the end of 30 days, the infant was clearly Cushingoid. They clearly had overdosed on the medicine. So clobetasol is going to be 27 times more potent than 1% hydrocortisone. So I think if you're planning on using it on a baby and you don't have a great experience and you're not a pediatric dermatologist, please ask a pediatric dermatologist or a general dermatologist even for advice before using it. I generally, if in your case, if you feel like you have that child that you want to put them on steroids, I think I'd maybe use it on a 5-year-old and only for a few days.
Great. We'll go with one last question because we're at the top of the hour. A dermatologist once told my friend that Vaseline may be allergenic to her. Do you have thoughts on that?
Well, I wish that I could have seen your friend and I wish I could have talked to that dermatologist because without knowing the specifics of the case, it's hard to make a good comment, except that I could say that Vaseline and other petroleum jelly is a semi-refined product of 16 to 18 carbon length chains of oil. So that if something is more refined or less refined, if you see the yellow color, which means it has a more of a tarry component than the more white refined component, any impurities in there could cause an allergic reaction.
All right. Thank you so much, Dr. Boiko. This was fantastic, as always. I just want to take a quick moment to remind everyone that your new CME process, you're going to click out of this webinar. It's going to show up on a tab. It's also the same website if you have that link saved. Complete your CME survey, and within 2 to 4 weeks, you will get that sent back to you. You'll get the certificate for this session completely. Any questions, please email me. And then last question, just to follow up to the Vaseline. So Crisco may be better for her?
So it's possible that somebody could do better with using a vegetable shortening than Vaseline if they have a sensitivity. And then there was one person who had a lot of really terrific questions and I wasn't able to answer all of them. There's no problem with sending me a MAVEN consult, not about a particular patient, but just with your questions about atopic dermatitis that I wasn't able to answer today, and I'm happy to answer them in that situation.
Right? Thank you so much. I'm just going to answer this really quick. Does a CME come to the register email? The survey link in the slide deck will be emailed to whichever you attended this session with. So whoever attended, that's where the email will go to. The CME survey is going to go, when you complete it, to the email address that you put in the survey. And we highly recommend, please, I'll beg you, to use the email that you use with MAVEN projects, whatever you sign into the platform with would be very, very helpful. All right, so I think we're done. I hope everyone has a great day, Dr. Boiko. Thank you as always. This was fantastic.